Good day. Today's topic of lecture, measles. Key facts about disease. Even though a safe and cost-effective vaccine is available in 2018, there were more than 140,000 measles deaths globally, mostly among children under the age of 5. Measles vaccination resulted in a 73% drop in measles deaths between 2000 and 2018 worldwide. In 2018, about 86% of the world children received one dose of measles vaccine by their first birthday through routine health service, up from 72% in 2000. During 2000 and 2019, measles vaccination prevented an estimated 23.2 million deaths, making measles vaccine one of the best buys in public health. Definition: measles in children, an acute infectious disease with fever, intoxication, catarrh of the upper respiratory tract, and mucous membranes of the eyes, as well as a spotty papular rash. On this slide, you can see the disease codes according to the international classification of the disease. About epidemiology. Measles is a highly contagious, serious disease caused by a virus. Before the introduction of measles vaccine in 1963 and widespread vaccination, major epidemics occurred approximately every 2 to 3 years, and measles caused an estimated 2.6 million deaths each year. More than 140,000 people died from measles in 2019, mostly children under the age of 5 years, despite the availability of a safe and effective vaccine. Measles is caused by a virus in the Paramoxovirus family, and it is normally passed through direct contact and through the air. The virus infects the respiratory tract, then spreads throughout the body. Measles is a human disease and is not known to occur in animals. Accelerated immunization activities have had a major impact on reducing measles deaths. During 2000 to 2018, measles vaccination prevented an estimated 23.2 million deaths. Measles in the pre-vaccination period was the most common infection in the world and was found everywhere. The incidence of morbidity every 2 years is explained by the accumulation of a sufficient number of people susceptible to measles. The incidence of measles was observed all year round with a rise in autumn, winter and spring. The source of infection is only a sick person. The most infectious patients in the cultural period and the first day of the appearance of the rash. From the third day of the rash, the contagiosity decreased sharply, and after the fourth day, the patient is considered to be non-contagious. Etiology. Measles is an acute viral disease of mainly childhood, characterized by general intoxication, fever, culture of the mucous membranes of the respiratory tract, and maculopapular rash. The causative agent of measles was isolated in 1954 by Anders and Peebles. Morphologically, it is similar to other paramyxoviruses. Virion diameter 150 to 250 nanometers, Virus genome is a single-stranded unfragmented negative RNA. The genome carries 6 genes of the following order: N, P, M, F, H, L. They encode proteins: nucleoprotein, phosphoprotein, matrix, fusion protein, hemagglutinin, and polymerase. A feature of the viral genome is the presence in its amphi-intergenic region of a large non-coding region of about 1000 nucleotides in size. Like other paramyxoviruses, the measles virus has hemagglutinin, hemolytic, and simplest forming activity, but it lacks neuraminidase. Hemagglutinin, hemolysin, nucleoprotein, and matrix protein differ in antigenic specificity and degree of immunogenicity. Hemagglutinin is the most immunogenic. With the help of monoclonal antibodies, several serovariants of the human measles virus were detected. It also has common antigenic determinants with the viruses of dog plague and rinderpest. Laboratory animals to the measles virus are unresponsive. Only in monkeys does the virus cause disease with characteristic clinical symptoms, and in the wild, monkeys can get infected from humans. In chicken embryos, the measles virus breeds poorly. For its isolation, primary trypsinized kidney cultures of monkey kidneys or human embryos are used, in which the virus during reproduction multiplies the characteristic cytopathic effect. However, the measles virus can also be adapted to cell cultures from the kidney of dogs, calves, or human immune cells, as well as to various transplantable lines. The virus can have a mutagenic effect on the chromosomes of cells. The virus is unstable, rapidly inactivated in acidic medium, reduces its activity at a temperature of 37 at 56, perishes in 30 minutes, easily destroyed by fat solvents, detergents, very sensitive to sunlight and quickly dies in the external environment. Resistant to low temperature. This circumstance should be considered when transporting and storing live measles vaccine. About pathophysiology. The entrance gates for the virus are the mucous membranes of the upper respiratory tract. There are indications that the conjunctiva of the eye can also be the gateway to infection. The virus penetrates the submucosa and the lymphatic pathways of the upper respiratory tract, where its primary reproduction occurs. When it enters the blood, where it can be detected from the first days of the incubation period. The maximum concentration of the virus in the blood is observed at the end of the prodromal period and on the first day of the rush. These days the virus is present in large quantities and in the mucosal membranes of the upper respiratory tract. From the third day of the rush, the secretion of the virus decreases sharply, and it is not detected in the blood. Viral neutralizing antibodies begin to predominate in the blood. The measles virus has a special tropism for the central nervous system, respiratory tract, and gastrointestinal tract. It has now been established that the measles virus can persist for a long time in the brain and cause a chronic or subacute form of infection. Subacute sclerosing panencephalitis is also associated with persistent measles infection. The appearance of a rash on the skin should be considered as the result of fixation in the vessels of the skin of immune complexes formed during the interaction of antigen and antibody viruses. Cells of the epidermis are dystrophied, necrotic, and when intensified keratinization of the epidermis occurs in the affected areas. followed by rejection. The same inflammatory process occurs also on the mucous membranes of the oral cavity. Degenerate, and when the horny epithelium grows too big, rises, forming small whitish foci of the superficial necrosis, spots of pelata coptic. On this slide, you can see the main symptoms of measles. The incubation period averages 8 to 10 days, may extend to 17 days. In children who received immunoglobulin for prophylactic purpose, the incubation period is extended to 21 days. In the clinical picture of measles, there are three periods: catarrhal or prodromal, rash, and pigmentation. After which the prodromal period begins, which is characterized by fever, catarrhal symptoms, dry cough, and tarsal conjunctivitis. Pathognomic coptic spots that appears on the 2 to 4 day of the disease, usually on the mucous membrane of the cheek opposite the first and second upper molars. They look like white grains surrounded by a red areola. They can spread, turning into a common erythema on the entire surface of the cheek mucosa, sometimes spread to the pharynx. Separate symptoms are observed from the second half of an incubation period. For example, weight loss, edema of the lower atelate, conjunctival hyperemia, sopfebril in the evening, cough, runny nose, and others. The rash appears on the 3 to 5 day after the onset of the initial symptoms, and on the 1 to 2 day after the appearance of coptic spots. A macula-like rash first appears on the face and then goes down the sides of the neck, acquiring the character of macula papilla. After 24 to 48 hours, the rash spreads to the trunk and extremities, including the palms and soles, gradually fading away on the face. In severe cases, there may be a petechial rash and ecchymosis. During the height of the disease, the temperature reached 40 degrees with the appearance of a periorbital edema, conjunctivitis, photophobia, dry cough, profuse rash, frustration, and slight itching. Common symptoms and signs correlate with rashes and the period of infectiousness. By the 3 to 5 day, the temperature decreases, the patient's state of health improves, the rash begins to fade quickly, leaving a copper-brown pigmentation followed by peeling. Immunocompromised patients may develop severe pneumonia and may not have a rash. Atypical measles can be observed in patients who have previously been immunized with a vaccine containing killed measles virus that has not been used since 1968. Older vaccines can change the course of the disease. Atypical measles can begin suddenly with high fever, prostration, headache, cough, abdominal pain. A rash may appear after 1 to 2 days, often starting on the extremities, may be maculopapular, vesicular, urticarial, or hemorrhagic. Swelling of the hands and feet may develop. Common are pneumonia and lymphadenopathy, which can last for a long time. Change on radiographs can stay for weeks and months. Signs of hypoxemia may appear. Bacterial superinfection is characterized by pneumonia, otitis media, and other lesions. Measles inhibits delayed hypersensitivity, which worsens the course of active tuberculosis, temporarily levels skin reactions to tuberculin and histoplasmin. Bacterial complications can be suspected by the presence of focal symptoms or recurrence of fever, leukocytosis, and prostration. After the resolution of the infection, acute thrombocytopenic purpura may occur, which leads to the development of bleeding, which can sometimes be severe. There are typical and atypical measles. With typical measles, there are all the symptoms of a disease. By severity, typical measles are divided into mild, moderate, and severe. Atypical measles include cases in which the main symptoms of a disease are erased, smeared, or some of them are absent. The duration of individual periods of measles can be changed. The shortening of a period of the rash, the absence of a cultural period, the violation of the stage of precipitation. Scraped or very light form of measles is called atypical too. It is observed in children who received immunoglobulin at the beginning of the incubation period. Mitigated measles occurs usually at normal or slightly elevated body temperature. There are no phyllatocoplic patches. The rash is pale, shallow, and grow sometimes only a few elements. The stage of the rash is disturbed. Cultural manifestations are very weak or completely absent. Complications with mitigated measles are not observed. A measly form of measles is often noted in children of the first half of life due to the fact that they develop a disease against the background of residual passive immunity received from the mother. Typical cases include measles with extremely pronounced symptoms, hypotoxic, hemorrhagic, malignant. They are observed very rarely. Measles in vaccinated live measles vaccine, in the blood of which no antibodies were formed, occurs typically and retains all its characteristic clinical manifestations. If measles develops with a small amount of antibodies in the blood serum, its clinical manifestations are erased. Petechiae are often located in the center of lighter colored macles. They are discrete lesions 1 to 2 mm in diameter. Confluence of lesions result in hemorrhagic patches, often with central necrosis. In some cases, a transient maculopapular rash develops, usually lasting for less than 48 hours. Rash may be missed early in an individual with dark skin. Critically ill patients with sepsis may develop rapidly progressing petechia, ecchymosis, and extensive palpable purpura, or retiform purpura, accompanied by DIC and vascular collapse. Skin lesions tend to occur in crops on any part of the body, occasionally presenting on the conjunctiva and the mucous membranes. The face is usually spared, and involvement of the palms and the soles is less common. About subacute sclerosing panencephalitis. The measles virus causes not only an acute productive infection, which is measles, but very rarely a severe slow infection, subacute sclerosing panencephalitis. It was first described in 1933 by Dawson and represents a progressive disease of the central nervous system in children and adolescents. Sick children become irritable, crying, they get frustrated with speech, vision is disturbed, they can't recognize surrounding objects. In patients, the intellect decreases rapidly, coma and death occur. The cause of this disease remained unclear for a long time. In sick children, anticorporal antibodies were found in huge titers, and in the brain cells inclusions characteristic of measles containing nucleocapsids like paramyxoviruses. Finally, strains similar to the measles virus were isolated from the brain tissue and lymph nodes of the dead people. The disease develops when the measles virus is introduced into the cells of the central nervous system. Propagation of the virus of these cells is disturbed at the stage of morphogenesis, apparently due to the absence of M protein. As a result, a large number of defective virions, deprived of supercapsid and M protein, accumulate in cells. Molecular mechanism of disruption of the synthesis of viral proteins can be different. One of them is related to the existence of a gradient in the level of transcription, which manifests itself in the fact that genes distant from the third end of genomic RNA are transcribed to a larger degree than genes located closer to it. With an acute measles infection, Transcription levels of near and far from the third end of the genus differ by no more than 5-fold when the PCPE with difference reach 200-fold level. This leads to a decrease in the synthesis of proteins M, F, and H, below the level necessary for the assembly and budding of the virion, formation and accumulation of defective interfering particles. Perhaps because the pathogenesis of PSPE lies in the violation of not only immune, but also some genetic mechanisms. About laboratory studies. In conditions of low incidence of measles diagnosis is complex and involves an assessment of the epidemic situation in the patient's environment, clinical observation of dynamics, and serological examination. A typical measles with spots of oblique, cough, runny nose, conjunctivitis, and a rash that appears first on the head can easily be diagnosed on the basis of a clinical picture. The main laboratory diagnosis of measles is general blood test and the serological blood test using the ELISA. General blood analysis, characterized by lymphopenia and neutropenia, which is associated with the multiplication of the viruses in leukocytosis and their subsequent death. Leukocytosis is indicative of an attached bacterial infection. Serological method of research. ELISA is most sensitive. It determines the immunoglobulin M titer. Therefore, in order to confirm the diagnosis, it is sufficient to examine serum, checking in the acute phase of the disease. Only once immunoglobulin M becomes available in the first 2 days after the appearance of rash, immunoglobulin G after 10 days, and reaches maximum values after 19 to 22 days. Before the onset of rash, the RNA of the virus is detected by the PCR method when examining blood and smears from the throat. About spinal puncture. It is carried out with the subsequent analysis of cerebrospinal fluid in case of suspected development of measles encephalitis. Lymphocytosis and increased protein levels are detected. Reef swab secret respiratory tract. Conjugated with the fluorescent monoclonal antibodies are used to detect measles virus antigens. In smears stained with conventional methods, giant multinucleate cells are found. With the development of crop, sewing is carried out from the tonsils and from the nose to determine the causative agent of diphtheria. Study of the coagulation system of blood. Produced in the development of hemorrhagic syndrome. Instrumental diagnosis of measles, chest radiography, echocardiography, is used for suspected complications. Differential diagnosis of measles is carried out with rubella, scarlet fever, infectious mononucleosis, and allergic rashes. Medical care. Etiologic treatment of measles is not developed. The introduction of anti-measles immunoglobulin is effective only in the incubation period. As a rule, the treatment of measles is limited to symptomatic and pathogenetic means. For example, treatment of the oral mucosa with a solution of nitrofural, vitamin therapy, instillation into a conjunctival, expectorant drugs with a dry obstrusive cough, antipyretic agents in age-related doses. When complications develop, treatment of measles is carried out according to the principles of treatment of these diseases. With the development of pneumonia or otitis media, antibacterial therapy is prescribed in accordance with the result of sputum culture for sensitivity to antibiotics. With the development of encephalitis, treatment is aimed at maintaining vital function and fighting swelling of the brain. Supplementary treatment of measles. Physiotherapy treatment of measles, a massage of the chest and respiratory exercise, appointed and controlled by the physician of exercise therapy. With the development of pronounced symptoms of laryngotracheitis are inhaled with alkaline solutions, bronchodilators, mucolytics. With dry cough and dry wheezing in the lungs, microwave and ultra-high frequency therapy is shown on the chest area. Diet and diet. A bed rest for the entire feverish period. The patient's bed should be with the head and to the window, so that the light does not irritate the eyes. Artificial lighting in the room or ward must be muffled. In the diet of a patient, it is necessary to include fruit juice, fruit drinks. The food should be high grade, rich in vitamins. It is easy to assimilate. Dairy products should be excluded from the diet. About prevention. Measles can be prevented with measles vaccine. Modern measles vaccine has prevented efficacy of 95 to 98%. In most developed countries, children are prescribed a leaf attenuated vaccine. The first dose is recommended at the age of 12 to 15 months, but during an outbreak of measles, it can also be given for 6 months. 2 doses are recommended. Children immunized at the age of less than 1 year will need another double vaccination in the second year of life. Vaccination provides long-lasting immunity and has reduced the incidence of measles in the, for example, United States by 90-90%. The vaccine causes lung or inapparent forms of the disease. Fever more than 38 degrees within 5 to 12 days after vaccination occurs in less than 5% of those vaccinated, followed by a rash. Reactions from the central nervous system are extremely rare. Vaccine does not cause autism. Modern vaccines, national vaccinations calendar. Live measles vaccine culture dry from Russia. Ruvax live measles vaccine from France. MMR2 live measles, mumps and rubella vaccine from Netherlands. Priorex live measles, mumps and rubella vaccine from Belgium. And a microencapsulated live measles vaccine is currently undergoing preclinical testing, and the measles DNA vaccine is under study. Contraindications to measles vaccination are systemic tumors, immunodeficiencies, treatment with immunosuppressants such as glucocorticosteroids, alkylating agents, antimetabolites, radiation therapy. HIV infection is contraindicated only if there is a pronounced immunosuppression. Otherwise, the risk of catching a wild strain overrates the risk of getting sick from a live vaccine. Vaccination should be careful in pregnant women, fevers, patients with active untreated tuberculosis, or refused antibodies. The duration of the delay depends on the type and dose of immunoglobulin, but can be up to 11 months. Measles susceptible children and adults in the case of contact with the patients, in the absence of contraindications, are immunized with live measles vaccine, but no later than 72 hours after the alleged contact, with a longer term from the time of alleged infection, as well as weakened presence of having contraindications to the administration of live measles vaccine. A normal human immunoglobulin is shown. Immunoglobulin administered intramuscularly in the first 6 days after infection protects against measles or facilitates its course. The method of non-specific prophylaxis is the early isolation of a patient in order to prevent the further spread of the disease. Patients are subject to isolation for 7 days, with the development of complication 17 days from the onset of the disease. Children who have not been vaccinated and have not been ill, who have come into contact with measles patients, are not allowed into children's institution for 17 days from the moment of contact, and who receive prophylactic immunoglobulin 21 days. The first 7 days from the start of contact children are not subject to separation. Emergency measles prevention is possible if it is administered within 3 days after contact with measles. If vaccination is delayed, serum immunoglobulin is administered, followed by vaccination 5 to 6 months later with no contraindications. Upon contact with a sick patient with immunodeficiency, which is contraindicated in vaccination, serum immunoglobulin is administered in a dose of 0.5 ml. Immunoglobulins should not be administered simultaneously with the vaccine. Prognosis. Measles has a favorable prognosis in the case of an uncomplicated course of the disease. With the development of giant cell pneumonia, encephalitis, and adequate late treatment, death is possible. In the case of the development of subacute sclerosing panencephalitis, measles in all cases has an unfavorable outcome. Goodbye, thanks for your attention, and be healthy. Thanks for your attention and be healthy.